So I guess we'll get started. I think people will be filtering in. We may have a little bit of a smaller crowd with the weather and stuff today, but we'll see. So this is Andy Saxon. I think lots of you know him already, as I do. He works over at the VA. Does a lot of addictions work. I think he's also a professor with the UW, correct? And the director of addictions work over at the VA, correct?
Well, actually, it's a Center of Excellence in Substance Abuse Treatment and Education, which is the title's a problem because substance abuse has gone away now, as you'll hear. So I have to figure out how to deal with what we call my organization. But
great. And then we were just chatting that Andy also has several grants to work on. I believe it's both pharmacotherapy and psychotherapy for addictions treatment. Is that right?
Right.
Yeah. So thanks for being here.
Okay. Great. Hello, everyone. You can see the topic is substance use disorders in DSM-5, and I won't be presenting any of my own data today because I haven't really studied this topic, but what I hope to do is give you some information on my take on the new criteria and some of the background of it, and some of my synthesis of the literature and some of the conversations that I've had with people who were on the committee who created the criteria. I have one disclosure in the last year. Reckitt Benckiser is the company that makes the brand version of buprenorphine naloxone. And so I guess you might worry that I'm going to try and convince you to diagnose opioid use disorder more frequently than you already do. And then maybe they'll sell more of this medication, but I don't think we can, even if we don't diagnose any more of it, we'll never get the number of patients who actually need this medication on it. And anyway, there's a bunch of generics now. So for my fellow Yiddish speakers, it might be more entertaining, but we are not going to be talking about the Diagnostic Manual of MISHEGAS. We're going to be talking about the Diagnostic and Statistical Manual of Mental Disorders, although some people have said sections of it are a bit of MISHEGAS, but I'm happy to say that the substance use disorders section of DSM-5 is, I think, a big improvement over DSM-IV, very rational, very workable, and makes a lot of sense, and that's what I'm going to try and talk to you about and convince you about today. And does anyone know, by the way, why they switch from Roman numerals to Arabic numerals, and why it annoys me so much when people who are putting this in writing write it as DSM-V? John?
5.1, 5.2, 5.3.
Yes, yeah, like so it's become a software program. But yeah, that's the rumor I've heard too. So, so the good news is if you, I don't think too many people who work in mental health really made a study of DSM-IV substance use disorders and carefully diagnosed them. But if any of you did, the good news is the translation over to DSM-5 is going to be pretty straightforward, and what you already know, you can make use of it in DSM-5. The even better news is for the majority of you who never learned the substance use disorders in DSM-IV, you won't have to, and DSM-5 is a lot simpler, a lot easier to learn, and I think, as I'll try and convince you, much more scientifically sound. So this is what we had in DSM-IV. If you had a substance use problem, you could possibly be fit into one of two categories, either substance abuse or substance dependence, and these are the criteria identical across all substances. So that creates sort of a dilemma for the diagnostician. Where do you put the person? We'll go over that in more detail. And then there are separate criteria, obviously, for intoxication and withdrawal on all the substances, which we're not going to go over too much today, except that in DSM-IV there was no cannabis or caffeine withdrawal, and they've been added to DSM-5, so we will talk about that. In DSM-IV, abuse was considered a milder form of the disorder, and people could begin with abuse, and if they worsened, move into dependence. Once they had dependence, they couldn't then go back and be diagnosed with abuse. If they didn't meet the full criteria for dependence, they could be diagnosed with dependence and partial remission. we really saddled ourselves with a problem when we called a substance use problem substance dependence in DSM-IV, because many clinical physicians get confused about the term dependence. In their medical training, they tend to think of dependence as physiologic dependence, that is, the existence of tolerance and or withdrawal. And so when we called what is essentially addiction dependence, they got confused and thought if you had physiologic dependence, then you had addiction. And so that's been a big problem for 25 years. And the SUD committee for DSM-5 wanted to clear that up. One of the options was to call the disorder addiction. And I think that would have been a great idea, and my understanding is half the committee really favored that, but despite the fact that I'm a member of the American Society of Addiction Medicine and the American Academy of Addiction Psychiatry, some people on the committee felt the term addiction or addict was stigmatizing. So we didn't get to that. We're going to be calling them substance use disorders. Here are the criteria for DSM-IV substance abuse. And you need to have one or more of these 4 criteria. And if you look at them carefully, you will see that actually if you have one or more of these things going on in your life because of your substance use, you're really pretty impaired. Yet this was supposed to be a milder form of the disorder. And I don't think anyone really knows how they came to a decision to put these particular criteria into abuse. But there wasn't much science behind it. And again, people who meet one of these criteria could really have a lot of problems. Maybe they don't have such a mild form of the disorder. And I'll show you some data on that in a minute. And here are the criteria for DSM-IV dependence. So what they've done here, now this does include the physiologic criteria, tolerance and withdrawal, which abuse did not include. And then it has 5 other behavioral type criteria, and since 3 or more were required to meet the diagnosis, you couldn't just have physiologic dependence and meet the syndrome of dependence. And I'm paraphrasing, these are not the exact words that you'll find in the DSM, I'm paraphrasing to fit them on the slides, and it's not really important that you memorize any of these criteria because you can always go to the book and look at it. So here is what we're going to be using in DSM-5, and it's going to be called substance use disorder, as in alcohol use disorder, opioid use disorder, stimulant use disorder. And what you have here, there are 11 criteria, and they took 3 from what was substance abuse, and they eliminated one of those, which is the legal criterion. We'll talk about that in a few minutes also. And they combined them with all the 7 criteria from what was substance dependence in DSM-IV. So 3 plus 7 is 10. There are 11 here, and they added a new one, which is craving. And craving was a bit controversial on the committee. There are some people who say craving is really the essence of addiction. If I'm walking around all day thinking about the cocaine that I'm going to use later or wanting to have it right now, that's really taken over my life. And there were other people on the committee who say, well, what is craving really? It's very subjective. How do you measure it? We're not sure. It means something different for every person. So, but they did end up adding it. And so now we have 11 criteria, and we measure the severity based on the number of criteria that someone meets, as you can see, from mild, moderate to severe. So we've gone from, what makes it simpler is we've gone from having to choose between 2 different diagnoses. We only have one choice now, and we can estimate the severity. One other point, you'll notice that tolerance and withdrawal have asterisks, and the reason for that is if the drug that the person or substance that the person is having a problem with is prescribed by a physician, probably tolerance or withdrawal are not going to count in the two that you're going to, at least a minimum of two that you're going to need to meet the diagnosis. So if you have, for example, someone who's treated with opioids for pain, benzodiazepines for anxiety, or stimulants for ADHD, those people, some people who get treated with those medications may have tolerance and withdrawal, and likely will have tolerance and withdrawal, but they may not have any of these other criteria, and they clearly would not meet the diagnosis. And if even if they do have tolerance and withdrawal, if you're thinking about diagnosing a substance use disorder for a prescribed medication, they're going to have to meet at least two of the other criteria. I took this from a paper that was in the Green Journal several months ago by Deborah Hassan, and I'm going to be citing a lot of her work. And actually, all the authors were the whole committee that put the substance use disorder section together. This just shows you schematically what I just said. So in the red, we have the old substance abuse criteria, and we dropped the legal. In the black, we have the old dependence criteria. And in the rightmost column here, you can see all the criteria, and craving is in blue, and that's been added. The new chapter name is Substance-Related and Addictive Disorders, so the people who like the term addiction at least got that in the title. And the reason they're calling it, the reason they have that title is because the gambling disorder was moved into this chapter, and we'll talk about that at the end. Let's move to some of the data that support the changes in the SUD section in the DSM. This could look like a pile of spaghetti. And this is an analysis using item response theory, which I will admit I don't fully understand, but I think the output makes some sense. And though it looks like a mass of spaghetti, the authors have very kindly continued that same color coding. So the prior dependence criteria are in black, the prior abuse criteria are in red, and the craving is in blue. And so what you have on the x-axis is the latent trait severity, so the severity of the disorder, and this happens to be for alcohol use disorder, and you can see the sample size is very big. This was an epidemiologic study that interviewed these many 30,000 people back in 2004 and 2005. And so as you move from left to right on the x-axis, you're seeing more severity of the disorder. And the y-axis is looking at the probability of the criterion being endorsed. And so the farther these curves are to the right in this graph, that's when a person gets that criterion when they have a more severe form of the disease. And right when the curves cross the 0.5 probability, the slope of the curve there tells you how well it discriminates. And that almost all these curves have pretty steep slopes there. There's a little variation. So they're all discriminating pretty well. You can see there are a lot of red curves that are over to the right, meaning that what was called substance abuse, those criteria do seem to appear in a more severe form rather than a less severe form of the disease. So lumping them all together makes a lot of scientific sense. And I'm showing you the one for alcohol, but there have been examinations of some of the other substances, and the curves that come up are pretty similar. I'm going to tell you about another study that Deborah Hassan did that I think represents some of the changes very well. She did this study in New York City. They had over 600 patients who were recruited from a variety of settings, and they underwent a structured psychiatric interview, and they did use these statistical techniques that, again, I'm pretty ignorant about, but I think I can interpret the output for you, and if there's anyone who understands it better and I garble it, I'm happy to be brought up short and told I'm wrong, because I'd like everyone to learn the truth. This just shows, looking at alcohol, the count of criteria that were endorsed by people in the sample, and you can see many endorsed none, and then the distribution of who endorsed how many, and there's a little bit of a bump out on the end where people endorsed a lot, who would be the people who have a severe form of the disorder. And these are the percentages that were of each criteria that were endorsed by the 534 people out of the sample who had used alcohol in the last year. So I want to bring your attention to a couple of points here. If I can make the pointer work. Here we go. So hazardous use is lower than most of the other criteria, and that might be an artifact in this case of where the study was done, because what is the most common way that people get into hazardous use with a substance? Right. And if you're lucky enough to live in New York City, you can get everywhere you want to go without ever driving. So it may be that they were very intoxicated on the subway, but that's not a big problem. But also, I want to bring your attention right below that to the legal problems, and a very small number endorsed the legal problems. So that's some of the basis of why legal was dropped from the new diagnostic set. And what we have here is what's called the total information curve. So the x-axis is similar to what I described before. As you go from left to right, there's more severity of the disorder, and each unit is a standard deviation away from the mean. And then on the y-axis, we're looking at how much information is given by the different criteria sets, and you can see where the distribution is. So for alcohol, that's the curve, and it's the area under the curve that tells you how much information you're getting. So that's the curve for the old dependence criteria alone, for dependence plus craving, for dependence plus abuse, and for dependence plus abuse plus craving. And dependence plus abuse for alcohol gives statistically more information than dependence, the old dependence alone. And craving is numerically a little better than dependence plus abuse, but it's not statistically superior. So craving doesn't hurt us there, doesn't help us, doesn't cause any problems, etc. Now we're moving into cannabis, and these are the people who endorsed how many criteria for cannabis use disorder. And here are the percentages. And in DSM-IV, there was no withdrawal, so that's why it's not applicable. And you can see there are much lower, with cannabis, there's much lower numbers than what's endorsed for alcohol. And again, we see the very similar type of situation with the hazardous use and legal problems. And here are the total information curves for cannabis. So that's dependence alone, dependence plus craving, dependence plus abuse. And in the case of cannabis, when you get to the 11 criteria with craving added, you do get statistically more information than you get with the old dependence alone. So it works. The new system works better for cannabis. And you can see that the curves are very far over to the right here, so you really don't even get much information to people with cannabis till people have a very severe form of the disorder. Here's heroin. Much more, many more people who've used heroin, or in this sample, many more people endorse. If they had any heroin criteria, they tended to endorse a lot. And again, more percentages of people who have used heroin are endorsing more criteria with the same issues for legal and hazardous use. And we get a similar kind of statistical result with dependence plus craving, dependence plus abuse, and then dependence plus abuse plus craving being better than the old dependence criteria alone at giving us accurate information about making a diagnosis. And finally, looking at cocaine, similar to heroin, if you're endorsing it, you're probably going to endorse a lot of criteria, because if you're using it, you're probably likely to have a very severe form of a use disorder. Again, the percentages that are endorsed, and again, the same pattern with legal and hazardous use. There's a little problem in this study with total information curves. You've got and again, it's the area under the curve, not the height of the curve. So even though dependence alone is higher, it's narrower and doesn't have as much area as the other curves. But there wasn't, although numerically it's going in the right direction, the dependence plus abuse plus craving was not statistically superior to the old dependence alone. So we're not doing any worse, but and this is only one study, but maybe for some reason that no one really understands, certainly the authors of the study didn't understand, the new system isn't much better for cocaine than the old system. It's no worse. So abuse and dependence criteria are better as a unified single dimension than as two separate dimensions. So it makes sense to have one diagnosis where we have a range of severity. So I think that is a big improvement. The legal criterion doesn't add much to diagnostic accuracy and really occurs when there's a very, very severe form of the disease. I mean, certainly, I'm sure in your program here, and definitely in the program at the VA, we see a lot of people who are involved with the legal system, and they are very, very severe, and there wouldn't be any question that having or not having a legal is not going to make any difference about our diagnosis with them. And the total area information, the curves that I showed you that show that except for cocaine, dependence plus abuse plus craving provides significantly more information than dependence criteria alone. So that's good. This is a completely different study with a similar analysis for tobacco use disorder, and you see essentially the same thing. So that's also good. We'll move into now looking at how might this shift in diagnostic criteria change the number of people who might get diagnosed with a disorder. This is a retrospective analysis that was done with people in the Virginia Twin Registry, and they had assessed them for DSM-IV, alcohol dependence and alcohol abuse. And so this isn't quite the DSM-5 criteria because they didn't assess them for craving, so we can't include that. So they're including everything that's in DSM-5 except the craving. And looking at comparing how many people would get diagnosed with an alcohol use disorder using the different criteria. So 2/3 of the people would not get any diagnosis. 28% would get a diagnosis with whichever system you used. 4% get a diagnosis, an additional 4% get a diagnosis only with the DSM-5, and there's an additional 2% who would get a diagnosis only with the DSM-IV. So probably slightly more people might get a diagnosis with if we use DSM-5, but it's not going to be anything that huge according to this study. And as you all probably know, the American Psychiatric Association did a DSM-5 field trial where they tested these criteria in real-life patients in real-life clinical settings. So this study came from the Houston VA and Meningers, and Meningers, as I'm sure everyone knows, has moved from Topeka to Baylor University in Houston. And they assessed the alcohol use disorder, and they were looking at reliability using the Kappa statistic when they had two different interviewers make the assessment for an alcohol use disorder. So about a quarter of, they did some screening, and about a quarter of that sample of a couple hundred people qualified to go on for a further diagnostic assessment of alcohol use disorder, and not all of them got assessed, and then not all of them made it to their second visit where they were going to have a second interview. But among those who did, about 60% did have a diagnosis of DSM-5 alcohol use disorder. The Kappa statistic was 0.40, which is, just even though I'm completely unsophisticated in statistics, just to show off what I do know, for those who don't know this, the Kappa statistic is used to adjust for the fact if you look at simple concordance, and you only have a yes-no choice, a lot of the time, 50% of the time, you're going to agree by chance alone. So I'm not sure we're thrilled with a Kappa like that. We'd like to see it higher, but they call it good. And it does suggest there's some subjectivity and based on the interviewer, or people don't always tell the different interviewer the same story they told the original interviewer, but the authors were happy with it, and the DSM-5 prevalence was about 30% among those who were among the whole sample, and the estimated DSM-IV prevalence is 26%. So this kind of agrees with the prior twin study that there might be a little higher diagnosis when we're diagnosing use disorder with DSM-5 compared to dependence in DSM-IV. Okay, so that covers the new diagnostic criteria for use disorder, and we're going to move into talking about the newer criteria for withdrawal that did not exist in DSM-IV. And here's just a study to illustrate cannabis withdrawal. These were daily marijuana smokers. They were assessed actually in their home environment, and they were given the opportunity to smoke as much marijuana as they wanted to or usually would over 5 days. And then they had abstinence enforced over 3 days, and the abstinence was confirmed by a creatinine normalized urine THC levels, and they rated their withdrawal symptoms on a scale of 0 to 4 on a daily basis. So here's decreased appetite, and you clearly see there are changes between the periods of marijuana use and marijuana abstinence, as we would expect. You're going to have, since cannabis stimulates the appetite, when you're in withdrawal, you're going to have less appetite. Irritability, similar kind of pattern, irritability going up during periods of cannabis abstinence. Sleep difficulty, same pattern. Restlessness, similar pattern. So that's only one study, but there probably are 10 to 20 studies in the literature documenting the same thing. And there was enough scientific evidence there to say we should have cannabis withdrawal in the DSM-5. And you need 3 or more of these criteria to make a diagnosis. So why is it important that we have cannabis withdrawal in our diagnostic manual? If one could argue about how much of a problem cannabis is for people without psychiatric disorders, but all the evidence we have to date is that cannabis is harmful to people with psychiatric disorders in terms of the course of their disorder. So we are going to be, and we all know that we have a lot of our patients who use cannabis, so we are all going to be in the position of trying to get our patients to relinquish their cannabis use, and we really need to understand that that's going to be an uncomfortable process. It's not just like, oh, I don't want to use it anymore, so I'll stop. They're going to be physically and psychologically suffering, and we need to be aware of that and figure out a way to coach them or treat them through that. Yes?
I have a quick question. Not quick. So if it's in the DSM-5, does that mean insurance companies now are going to pay people to be in a detox program for cannabis withdrawal?
I don't know. There's probably someone here who knows that better than I do, because working at the VA, I'm real lucky that I never have to deal with private insurance. So does anyone, I would suspect we could make a strong case for that. But does anyone, well, I think we should lobby the insurance companies, especially with parity now available. If they're going to pay for alcohol withdrawal, they ought to pay for cannabis withdrawal. The other reason why this is pretty important to know about is Barbara Mason just did a study looking at gabapentin. It's a placebo-controlled double-blind study for cannabis use with use disorder and withdrawal, and you can clearly see that the people treated with active gabapentin had less severe withdrawal over time than those who were treated with placebo. So not only do we need to recognize it, we actually have a medication that's generic, inexpensive, quite safe, and widely available that we're all experienced with that we could treat this with. So, yeah, that's John.
Is that, these are weeks of withdrawal, so the differences start to emerge after 3 weeks of withdrawal?
Correct. But these are people, remember, these are people who are out in the real world with access to cannabis, so it's not like... Correct. So they came into the study, they're trying to quit, but it ain't that easy, so they're having some cannabis use, and if you look this paper up, you'll see the data on the use, which is also less with gabapentin, but since we're talking about withdrawal here, that's what I'm putting up. But yeah, so they're going to be it's kind of like a little bit like the study I showed you. I mean, they're in their home environments, and although no one's telling them when they can and can't use cannabis, they're trying to quit, and they're going to have periods of trying to quit. And they're telling the investigators, yes, if I got the gabapentin, my withdrawal wasn't so bad. Does that make sense?
Yeah, but they were using a lot more than their withdrawal wouldn't do that either.
Correct. So there may be an interrelationship there, but it looks like the gabapentin's doing something. So, yes.
They look at different doses.
They only looked at this one dose. So theoretically, you could go higher. Yeah. So it's important. And then caffeine withdrawal. This is probably something that more of us have some experience with. And so my own experience was 25 years ago. It was the day of my father's 65th birthday party, and I went to visit my parents and got up that morning and had breakfast, and we drank our coffee. And during the day, I was kind of like, I don't feel so good. Am I getting the flu? I got a terrible headache. And we had this party, and I had all this great toast I was going to give to my father, and I didn't even feel well enough to get up and say anything. And then went to bed, and the next morning I still felt even worse, and suddenly something clicked, and I said to my mother, did you give me decaf yesterday? Yeah. Is this decaf? Yeah. So I'm scrabbling through the cupboards looking for, this stale instant coffee, and so that's when I decided to give up caffeine. But so this study, normal adults that are averaging 2.5 cups of coffee a day, and they put them on first they see how they answer their questions on their regular routine, then they give them a caffeine-free diet with placebo capsules, and then a caffeine-free diet with caffeine capsules that tries to mimic the amount of caffeine they get every day. So the data are no surprise. Percentage of subjects having a headache on placebo, having fatigue on placebo, having a low mood on placebo, and that leads us to putting caffeine withdrawal into the diagnostic manual. And again, I think this is very useful. I don't know about you folks, but a lot of my patients drink prodigious amounts of coffee and other caffeinated beverages, despite the fact that they might have a trauma-related or anxiety disorder, despite the fact that they have insomnia, despite the fact that they have essential tremor. And we want them to cut down on their coffee. Luckily, at least with coffee, we don't have to tell them they have to entirely quit. I mean, they can just get to a reasonable amount. But we really have to, it's not something that people can change very easily when they're having such terrible symptoms. So we need to come up with a way for them to taper off. And I usually recommend substituting part decaf rather than just trying to reduce the amount they're consuming. Do half and half, a quarter decaf, half and half decaf, and gradually taper down. Now, that worked for me personally, but I don't know how well it works for the patients. But they try it. So, okay, yeah.
I also have had patients who consume large amounts of Mountain Dew, for whom I recommend mixing soda water and increasingly less Mountain Dew because you still get a lot of the flavor.
Yeah, okay, yeah, so that's exactly the same paradigm, just with Mountain Dew instead of caffeine. And for those, I assume everyone knows that Mountain Dew is the soft drink that has the most caffeine in it, even though it's not dark and rich looking. But yeah, so good plan. The new diagnostic criteria, I think, as I've tried to make a case, are much, much better. And I'm going to tell you about a few other little changes here, but they're not perfect, and there are some glitches. So nicotine dependence becomes tobacco use disorder. And I thought this was, until 2 days ago, I thought this was just great, because we use nicotine replacement. We tell people that, at least I do, you can stay on this as long as you need to stay on it. It's much healthier for you than smoking tobacco or chewing tobacco. It's not a big deal. So it shouldn't be nicotine dependence. But then one of my patients who's a Gulf War veteran who has Gulf War syndrome, and PTSD, and the Gulf War syndrome manifests primarily with her as chronic pain, and so she. But I did a couple years ago work with her and get her to successfully quit smoking, which was wonderful. But she shifted over to the e-cigarette. And so she was telling me Wednesday, I might be overusing that, like I'm getting a little more anxiety because I can use that anywhere, whereas before when I had to smoke, I had to go outside. So I'm not sure. I don't have a diagnosis for her because there's no nicotine dependence anymore. So I'm perplexed about that. The amphetamine-type substances and cocaine are now lumped together as stimulant use disorder, and certainly their intoxication and withdrawal criteria are all identical, but there are some pharmacologic differences between the two drugs, and although the behavioral treatment is fairly similar and there are no FDA-approved medications, some of the research on medications would suggest that different medications might work for one or the other. The trouble is on the East Coast, they just think of amphetamine as a long-acting form of cocaine, and they don't really understand some of the differences that we see out here. So I'm not thrilled with that change, but we can live with it. There used to be a specifier on agonist therapy, which has been changed, I don't know why, to on maintenance therapy. So methadone or buprenorphine for opioid use disorder, or NRT for tobacco use disorder. That's a new name. The remission criteria have been changed a bit. There is early remission, which is no criteria met except craving. So you can have craving and you're in remission for at least 3 months. It used to be one month in DSM-IV, but less than 12 months, and you've got sustained remission. No criteria except craving for 12 months or longer. That sounds fine, but there used to be a partial remission. So if you needed 3 criteria to meet dependence and you had 2 criteria, you'd be in partial remission. You'd have to have 0 criteria to be in full remission. Well, I didn't even think about this glitch, but my staff brought this up to me. Well, what if you have substance use disorder, which requires 3 criteria? It requires 2 criteria, and you drop to 1 criterion. It's not craving, so you're not in remission, but you don't meet the 2 that you need, unless you have craving also, you don't meet the 2 that you need to have the disorder. So these people are in nowhere land. I don't know what to do about that. Finally, we'll move on to talk about gambling disorder. Why would we classify this with the substance use disorder? They co-occur very frequently, and the neurobiology looks pretty similar. So basically what that means is if you put someone in a neuroimaging scanner and they have a gambling issue, and you have them play a gambling game and they are anticipating the outcome of their play and their bet, the brain reward pathways are going to light up. They get the same kind of neurobiological change as someone who's thinking about using a substance or has just used a substance. So they moved it into this chapter. These are the DSM-IV pathological gambling, 5 or more required for diagnosis. Again, there are paraphrases, and I'm not going to go over these because anyone can look in the book and you can scan them now. They did change the name, which I think is a better change, from pathological gambling, which is kind of stigmatizing, to just gambling disorder. And there's 9 here instead of 10. They dropped the legal, just like they did with the substance use ones, but they also dropped the number required for diagnosis. In this little study, they looked at the comparison of using the DSM-IV to diagnose gamble. I have it labeled as pathological gambling, which it was in DSM-IV, but we're really looking at the gambling disorder. So if you can see the numbers here, you're going to be diagnosing a few more people if you're using the DSM-5. They looked at DSM-5 just dropping legal and still requiring 5 criteria out of 9, and then they looked at what's really going to be, what the real criterion set is, which is only requiring 4, and then they looked at what they call a SUD adapted, where they're trying to really fit it into the pattern that we use for the substance use disorder diagnoses. But it looks pretty good. We will diagnose a few more people with gambling disorder, and I don't know if that's a good or bad thing, probably a good thing, and we're probably not diagnosing that often enough. So we're at the summary, and the 2 old diagnoses in DSM-IV, again, are being brought together. They're going to unify on a single dimension. That works really well because we get more information. from bringing them together, dropping the legal problems. What I put here on the slide is craving neither significantly detracts nor adds to diagnostic information. And actually, it looked like in the study I showed you for cannabis and heroin, it actually did add to the diagnostic information. So it certainly may help a little bit. The other big thing with craving is part of the criteria set for ICD-10, which we're all going to be moving to treacherously soon. So it's nice that our criteria that we use in the U.S. will accord with the criteria that everywhere else in the world uses as well. So craving is going to be there. There's 11 criteria. We're losing the terms abuse and dependence, which I think is a great thing because they both cause problems, particularly the dependence. I think it's good that we're adding cannabis and caffeine withdrawal. The gambling disorder has been moved. And we should have some time for questions here, for discussion. Christine.
Hi. How do you feel about adding the gambling disorder into substances? Because there are other, behavioral addictive disorders like sexual addiction, for example, or and other things like that that sort of fit the same pattern. And they're in, is that right? They're still in impulse control disorders?
Yeah, they would be NOS if anything. So I don't think there's internet ones. There's probably many more I don't even know about, but I know about sex addiction. I know about internet addiction. I know about shopping addiction. Are there some others? So yeah, I think it's a good question. And how do they differentiate from impulse control disorders or even obsessive compulsive disorders? And I don't think we really know, but I do think I'm encouraged that with all the research going on in about 10 years, we will have a much better idea of where these things fit and how they interrelate. I'm okay with putting gambling disorder there because I think the point was made on the slide, I didn't emphasize it too much, that many people who are coming into our addiction programs are going to have gambling disorder. We don't often ask about it, diagnose it, or treat it. And maybe having it there will raise our attention to the fact that we should be asking people about their gambling and trying to intervene. And I think the treatments are pretty similar. So the behavioral treatments are quite similar. Just like you might refer someone to AA, you would refer someone to GA. And if you're going to use professional treatment, it's usually some form of cognitive behavioral therapy. And actually, if you're going to use a medication, the medication that looks the best right now is an opioid antagonist like naltrexone or nalmefene, which also works for alcohol and opioids. So I think it is reasonable. The other ones are a little bit less certain to me, but if they really are an addiction. I mean, sex is a very normal human behavior, and theoretically, we had coca leaves till 150 years ago, but we never had cocaine, so that was not something we evolved with and that the human brain was adapted to. So to me, that's a little different. But anyway, yes?
I'm recalling that some recent, I think neuroimaging studies have differentiated sexual addiction as not operating in the same pathways as drug addiction.
Okay.
That was actually biologically started to say that these systems are different.
Okay, so that for those who are looking remotely, the comment was that the neurobiology of excessive sexual behavior, so we may not want to call it sex addiction, is probably different than the neurobiology of substance use disorder. So maybe it shouldn't fit here, John.
That's on the next season of Masters of Sex.
Okay.
We'll have that.
Other comments or questions? Yes.
There's a case I evaluated recently in which a woman started dancing after she became interested in public assault. And so her ultimate goal was to get dancing. So that's factor in pretty
So just let me summarize the case and the question for those who are remote. So this is a woman who didn't have any problems until she contemplated doing some charity work in Africa, and then her method to obtain the funds to do her charity work was to begin gambling, and then I guess she got in some legal trouble with her gambling. And the question, it sounds like a somewhat unique case, but I've definitely seen patients who, for one reason or another, start gambling later in life. Now that's confounded by the fact that until, 15 years ago, it wasn't that easy to gamble. We didn't have internet gambling, and there wasn't a casino in every, So part of it's exposure. For example, in the Muslim world where alcohol is religiously forbidden, people don't get exposed to alcohol as much, and so they're less likely to develop a problem with it.
Would you tell the attorney what she does or does not?
Well, I would go through the DSM-5 gambling disorder and see if she meets the criteria. And if she meets the criteria, she has a gambling disorder. That DSM is silent about what causes the disorders. You're just looking at the phenomenology and making a diagnosis. So the causes of all of these disorders are very complex, with genetic and environmental factors converging in different individuals. So it sounds to me like she probably did, but we'd have to go through the criteria. Chris?
Andy, thanks for doing all the homework. All this stuff. I wanted to know about the cravings. How everybody knows that it's complex. It goes from mild to severe. It's camouflage sometimes isn't linked to food. Is there a standardized assessment battery? How would you assess for cravings?
Yeah. So
yeah,
the,
your checklist.
So the question from Chris Dunn is, what's the best way to assess for craving? And I don't have all the answers on this, so I think you in a clinical context, and I simply ask the patient how much they think about it and how they think about it in their everyday life. But if in a research context, there are a variety of craving scales and measures for almost every substance, but what's also often used is just a visual analog scale where you've got a 100-millimeter line and you ask the person to rate his or her craving by making a vertical mark on this line, and then you've got a numerical score between 1 and 100. I think that works pretty well. We've had enough craving studies done, and now that it looks like those are pretty accurate type measurements. So I think there are plenty of ways to do it pretty well that are pretty well validated. But clinically, you could use one of these rating scales, but I don't think it's necessary because I think patients can tell you pretty readily.
I like that they allow for cravings to go out past 12 months. That matches with my clinical community.
Yeah. I have patients who, I have one patient actually who's a Vietnam veteran who has been abstinent since 1990, and he was just telling me when I saw him last week that he's still having drug dreams occasionally. I asked him, are you at risk to use? No, I'm not at risk to use. He has a family now, he owns a home, he's doing really well. He remembers how bad it was when he was using, but that doesn't mean he doesn't think about it sometimes or have some craving or dream about it. So yeah, that does go on. Yes?
I do that. I'm an addiction counselor on inpatient, and sometimes I'll use the craving law because they're in a safe environment. Same thing, on a scale of 1 to 10, what were the thoughts and feeling? How did you cope? Because they kind of get some used to practicing there in the safe environment before they're back in.
Yeah. So a good comment that on an inpatient unit, it's safe to use a craving scale from 1 to 10 and get people to acknowledge and be aware of their own craving and how that they need to think about how they're going to manage that when they get discharged, like tomorrow from the inpatient unit and they're back in the real world. Yeah. Yes.
I had a question about marijuana withdrawal. On the slide, there was data for using marijuana scale of restlessness and then the withdrawal period.
Yeah.
But I was wondering if there was data for baseline appetite, and so whether there's an absolute decrease in appetite when you're withdrawing from marijuana, or whether it's just relative compared to the high appetite they have when you're using. Does that make sense?
Not totally. So the question is, what is they? Well, I mean, they had an appetite when they had a high appetite when they were using, and I think what the slide said is decreased appetite. So we're looking at an increase in the decrease, so to speak. So that maybe that's where it's confusing. But they still had some appetite. It wasn't like they were anorexic, but their appetite was decreased during the withdrawal period. So are you asking what would they have been like before they ever started using cannabis? Or
Did it decrease the normal appetite, or did it decrease?
Yeah, no, I don't think that's measured, and I don't know quite how you would measure that. I mean, you can't find these people before they started using cannabis, so, but it definitely, I mean, clinically, so that was a study. Clinically, I think what you will find is people are probably wanting to eat less than would be a normal diet if they're really in severe withdrawal. John?
Somebody wanted a research project. The use of cannabis is going to go up quite a bit in the state in the next year. And I suppose you could do prospective studies to someone's life. Look at some of these questions.
Yeah. We're going to have a great natural experiment going on. I think we already do. But,
Weight Watchers is just getting ready for it.
Yeah.
Scale up.
I know there's pretty good evidence for like subacute extended alcohol withdrawal symptoms. Is there similar evidence for other substances that you know of?
It hasn't been studied real well in a rigorous way, but if you talk to the patients, it's kind of similar to what the question is subacute or protracted withdrawal symptoms, which are past the period of time where we can observe physiologic signs of withdrawal, but the patients are reporting symptoms. So if you talk to the patients, it does go on with, they're pretty good data for the alcohol, as you say, that it goes on beyond the 5 or 7 days where we can observe any signs of withdrawal, physiologic withdrawal. So you've got things like insomnia, increased anxiety, restlessness, etc. It's really hard to study out beyond a few days, but I think actually John was questioning the data I showed you on the marijuana withdrawal because it was over time and they were still using, but it looks like those people are having some withdrawal symptoms over a prolonged period of time. So my experience in talking to patients is, yeah, it's subtle, but it's there, and if you can deal with it, that's helpful, and you can deal with it behaviorally, psychotherapeutically, by getting them to recognize what the symptoms are and trying to teach them some skills to deal with those symptoms, whether it be insomnia or anxiety or whatever, or you can deal with it pharmacologically. In the case of the cannabis, it looks like gabapentin works, and we have obviously also very good medications for opioid use disorder and for alcohol as well. So it's a really important point to keep in mind. Nothing that has anything to do with the DSM-5, but very important clinically. Yes,
There was
Chris.
a recent study where they looked at using gabapentin in people that were abusing or using alcohol, and they had about 40% of the people had a decrease, the heavy users had a decrease in that. What's your sense and your experience? Does it make a difference in that way?
So Barbara Mason, who did the cannabis study, is the same one who did the alcohol study, and I heard her present, and I've read the paper and looked at her data. I don't have a lot. I've tended to use the FDA-approved medications like naltrexone, disulfiram, and acamprosate to treat alcohol use disorder, which aren't always successful. I haven't tried gabapentin. Rick Reese isn't here. I think he's used a lot of gabapentin. He's really positive about it, but I'm going to be, now that that's come out, I'm going to be using a lot of gabapentin, and I was telling John beforehand, there is a study also done at Medical University of South Carolina where they combined gabapentin with naltrexone and got a better result than naltrexone alone. It's a pretty benign medication, so I'm actually really encouraged that it seems to be working for the cannabis and alcohol. And actually there's another study that just came out, which was a sleep study showing that gabapentin improves sleep in newly abstinent people with alcohol use disorder. So it's kind of exciting that we have this medication that it's been hard to get people to use the alcohol treatment medications because they're not familiar with them, but we're almost all familiar with gabapentin and feel very comfortable using it. So I think that is going to be a breakthrough. Chris?
This is like Harvard used vitamin C. Good for chronic pain, sleep, marijuana, withdrawal, alcohol. Is there a neurological common mechanism?
Yeah, it's John will probably correct me, but my understanding, I mean, it's called gabapentin because it's believed to act on the GABA system, which is, it works on the glutamate system. No, it doesn't do any of that. Okay.
It's a calcium channel.
It works on, it's like most of these channel active things. It binds to a lot of proteins, and I don't know if they know how.
Okay, so the expert in the room says we don't know how it works. It binds to a lot of proteins. So that's too bad because that's true of all the other medications we use, and except for the alcohol and opioid treatment medications, those are the only ones in psychiatry that we really know how they work. But I thought we could know how this works. So I'm not quite as enthusiastic. But,
But the good news is it's not a GABA actor, so
it's not going to cause. I mean, I think people may have some. If they go off of it abruptly, they might have some symptoms, and so we usually try and taper it. But they're not. It's not a reinforcing type of medication. And some of the benzodiazepines, I mean, I can't remember the last time anyone said that. Gee, I'm going around the city looking to get my chlordiazepoxide that I can use to get high on. I mean, there's some benzodiazepines that aren't so reinforcing either. So I think we're at the end here. We're past the end. Thank you all for coming, and it's been a great discussion.